Welcome to this episode of Nursing Edge Unscripted, Saga, where we journey through the history of nursing education using stories that connect the past to the present and then our future as we reimagine our teaching and learning. This special episode of Saga is dedicated to a leader in the use of simulation in nursing education in recognition of Healthcare Simulation Week, celebrated in the month of September. This episode is a first-person account in the words of Dr. Marianne Rizzolo as she pays tribute to Debra Spunt, a pioneer and leader in simulation. Let me share Dr. Rizzolo's words. When was the first time you saw students engaged in simulation? When did your school or institution get its first mannequin? Whenever that was, Debbie Spunt had done it years earlier. She recognized the power of simulation for educating healthcare professionals, and in 1998, she became the director of the 28 clinical sim labs at the University of Maryland's School of Nursing in Baltimore. Then she really went to work, co-authoring the International Nursing Association for Clinical Simulation and Learning, INACSL, as we call it today, and becoming its first president. Her labs served as national and international models for student learning. Her expertise for integrating the use of clinical simulation within the educational curriculum garnered worldwide recognition. She toured numerous faculty and international visitors through the labs and provided formal and informal consultations to schools of nursing and healthcare agencies in more than 38 states and 12 countries, including South Korea, Israel, and Canada. The University of Maryland School of Nursing was twice named a Center of Excellence in Simulation Education by Laerdal Medical, an international manufacturer of interactive computer and patient simulators for educating healthcare professionals. I had met Debbie several times at Learning Resource Center conferences and other events, but I didn't really get to know her until Dr. Pam Jeffries and I worked with her on the landmark National League for Nursing Laerdal simulation study, designing and implementing models for the innovative use of simulation to teach nursing care of ill adults and children, a national multi-site multi-method study in 2003. Until then, only anecdotal evidence was being reported about the advantages of simulation, but it needed to be backed up with well-designed and executed research. Debbie was one of the first people selected to participate in the study and was clearly the most experienced. 7 other faculty members from schools across the country were selected. Debbie never flaunted her expertise, but provided leadership in her own quiet way. The group of 8 strangers developed quickly into a close-knit family with Debbie as the big sister. She was a very private person and rarely talked about herself, but she loved to talk about her daughter, Ellen. In 2006, as the study was in its final phases, we decided to use the NLN's Technology Conference to disseminate the outcomes of the study and to hold that conference at the University of Maryland. Debbie was thrilled that we were using her school where she earned her baccalaureate and master's degrees and where she was coming close to completing her DNP program. She welcomed all the attendees and was in perpetual motion during the event, speaking from the podium and providing tours of her labs. A few short months later, Debbie learned that her cancer had returned and further treatment was futile. When Tor Laerdal, chairman and CEO of Laerdal Medical, became aware that Debbie was terminally ill, he contacted the NLN to establish a way to honor all that Debbie had done for simulation and nursing. I visited Debbie just a few days before she died to tell her that a lecture was being established in her name. She was all dressed up in her cap and gown. She was so proud of that doctorate and thrilled and honored that her contributions would be recognized every year at the NLN Summit with a lecture provided by others who have had a lasting impact on the evolution of the art and science of simulation. Following Dr. Spunt's death at the age of 50 in March of 2007, the school named the labs in her memory and established the Debra L. Spunt Clinical Simulation Practice and Research Endowment, which allows the University of Maryland School of Nursing to remain on the cutting edge of simulation education. Everyone who knew Debbie has very special memories of her and her impact on their life and work in simulation. Mine is seeing her at her induction into the Academy of Nursing. She was so proud to have her daughter Ellen with her on such a special day. My other special memory is bittersweet, seeing her face light up when I told her about the endowed lecture funded by Laerdal that would carry her name. When I asked Debbie to select the first person to deliver the Spunt lecture, she quickly replied, "Pam, of course." Then, from her bed, she pointed to a small framed picture of her and Pam in full finery, taken at the Academy induction ceremony. She told me to give the picture to Pam after she delivered the first Spunt lecture. 6 months later, I did so from the podium of the NLN Summit, fighting back tears. While there is no question that Debbie's pioneering efforts and leadership brought simulation to the forefront, I think it was her warm personality and giving spirit that was equally important. She was one of the kindest and most generous people I have ever known. She was quiet and unassuming and always willing to share whatever she learned with others. All you had to do was ask or let her know you were struggling. Debbie recognized the benefits of simulation early on, and the art and science advanced more quickly because Debbie was there, freely sharing her knowledge during the earliest days of simulation's use in nursing education, cheering everyone on. Every new innovation, especially in education, needs someone like Dr. Spunt so that the diffusion of innovation cycle accelerates newly found knowledge about the best ways to educate our students and find its way to the educator toolbox quickly with an outcome of better educated students and better patient care. Thank you for all you did to lead and inspire us, Dr. Debra Spunt. You touched our minds and our hearts, and we miss you still. And thank you, Dr. Marianne Rizzolo, for your wonderful accounting of Debra L. Spunt. And so the saga continues, and may our saga continue as we bring to a close this episode of Nursing Edge Unscripted, Saga. Thank you for joining us, and remember, good teaching doesn't just happen. Find your fit, push the boundaries, and celebrate the ahas.
Welcome to the 2023 Debra Spunt Lecture, Please welcome to the stage the 2023 Spunt Lecturer, Dr. Kellie Bryant, Assistant Dean of Clinical Affairs and Simulation and Associate Professor at the Columbia University School of Nursing.
Good morning, everyone. Good morning. It is a privilege and honor to be here today to provide the Debra Spunt Lecture. Particularly an honor because I'm following in the footsteps of some of the simulation leaders that I've followed my whole career. I would like to take the time to thank Laird Our Medical and the NLN Foundation for continuing to have this endowed lecture. And also I want to thank all of you for waking up at 8:15 in the morning, very early, to be here with me today. So I want to start with a story. And this is a true story. 2 to 3 years ago, I received a phone call from a simulation colleague. And he called me because he had a sentinel event that happened at his hospital. And the event goes a little bit like this. There was a patient that came to the hospital system that was known to the system that he would come on a regular basis for alcohol intoxication. So he came this particular day, and he was complaining of stomach pains. And let's just say he did not receive the optimal care that he should have received. So he told me the rest of the story, and I said to him, we can turn this into a simulation. Because he was now responsible for implementing a system-wide implicit bias training. So we got together, and we created this simulation that he was using at his hospital, and we were also going to use at my facility as part of implicit bias training. So before I show you the video, I'm going to ask you to think of two questions I'm going to ask you as you watch this video. The first is, why do these medical errors occur? Why do these medical errors occur? I'm going to repeat it. And then number two, what can we do as nurses, as nurse educators, to advance health equity? Okay? Those two questions. And let's play the video.
So I'm going to put in an order of pain meds for Ms. Engel, if you can get that for her ASAP.
Okay,
Who we
no
got
problem.
next?
We got our favorite frequent flyer.
Oh,
Lee Mitchell's back again.
Lee? Okay.
Yeah.
What's he want? Same old story?
Same old. Something about his stomach hurts.
Yeah.
But, yeah, that's
Okay, I'm
about
going
it.
to check on what room's he in?
He's in 309, but be
Yeah.
prepared. It's not like he hasn't taken a shower in a few days.
Okay.
All right,
Well, yeah, I'll check on him. If you can get that order for Ms. Engel, I'll be back to check on her tonight.
okay, and I'll meet you in there in a minute.
Great, thank you.
All right.
Haley,
Hey,
long time no see. What's going on today?
my stomach is hurting.
Yeah?
Yeah,
I understand you were just in last night, yeah?
yeah.
Okay. And how many drinks have you had since then, huh?
No drinks.
None?
Nope. Zero. No
Okay.
drinks.
All right, if you say. But you said you got some pain, huh?
Yeah.
Hey, can you point out where your pain is? Okay.
My stomach.
Yeah, well, you know, drinking can cause that, right? Some inflammation.
No drinks.
None?
Mm.
Well, we want to get you some drinks. We want to get you some water, so we're going to get you hydrated. Let's get him some food, too.
Do you want me to start an IV?
Oh, no.
I'm not hungry.
Not hungry? No? Okay, well, so at least get you some water, okay?
I just want something for my stomach. It's hard to get something from my stomach.
Yeah, well, we'll check on that, but we're going to get you some food, and we're going to get you some water first, and we're just going to let you sleep it off, okay? So you just take it easy, and we'll come back and check on you in a little bit. Sound good?
Stay home for this.
Yeah.
Just slept at home.
Take it easy. We'll be right back, okay? All right?
So let me tell you the ending to that scenario. When they went back to the room to check on that patient, the patient had died. So again, I go back to those two questions I asked earlier. Why did these medical errors occur? And what can we do to advance health equity? We all, whether we're doctors, nurses, we all go to school and we're educated. We're supposed to take the best care of our patients, good quality care. But what were those practices? What were those beliefs? What were those biases that prevented that patient from getting the optimal care that he deserved? And think about how we can take this unfortunate incident and turn this into a lesson, an educational session, whether it's playing this video or playing it out in a scenario, where we can talk about the bias and discrimination this patient faced. This person was unfortunately faced housing instability. He was African American, and he had alcohol use disorder. When we watch that video, let's ask our students, what made you uncomfortable? What were some of the things that you saw the healthcare provider do that may have contributed to that outcome? What did I do or not do in that video where I could have advocated for that patient? What else do we need to do to advance health equity so these situations don't happen? Because these situations happen way too often. So we're going to continue. We're nurses, nurse educators, of course, we have to start with the objectives. What I'm hoping that you get out of today's lecture is that we leave here and be able to discuss what are those factors that contribute to health disparities? What is our role as nurses, as nurse educators, in championing for health equity? We play a pivotal role in advancing health equity. And lastly, we're going to explore some educational strategies, some approaches on how we can empower our students to be advocates for their patients. And part of that, of course, is simulation. So I want to start with telling a little story about myself. So when you look at this picture, this is a picture of my high school yearbook picture. Maybe not my page, because I couldn't find my page, but what do you notice when you look at this picture? What's striking to you? It lacks diversity? Yes. So there are 256 pictures on this page, I counted, and I think there's about 98% of the people in this picture are white. And that actually represents the demographic of where I grew up, which was a small town called Colony, which is located near Albany, New York. It was 97% white, 2% black. So I was the only black child in my neighborhood. And I say that because that came with some difficulties. Name calling. I had kids in the neighborhood say they couldn't play with me because I was black. And when we talk about diversity, equity, inclusion, where I grew up was everything but that. It wasn't diverse, it was not equity, and I definitely did not feel included. So I tell you that because so you can understand my lived experience and why I'm so passionate about this work. And this is a picture of my grandmother. This is, as I affectionately call her, Grandma Gertrude. And this is Grandma Gertrude on her last day of nursing school. And I had the privilege of growing up with Grandma Gertrude later on in my life. And I used to visit her every week. And Grandma Gertrude had no Nintendo, I know I'm dating myself, no cable. All Grandma Gertrude had at her house was her nursing books. And guess what? I actually sat and used to talk to my grandmother, sit at the kitchen table and talk. And she would share all her stories about nursing. And of course, this is my biggest inspiration for me to be a nurse. One story stood out in particular. She was telling me about how bad she wanted to be a nurse and how she applied to nursing school, and she did not get in. She was denied because of the color of her skin. In 1973, she finally got into nursing school. Medgar Evers was the only school that would let her start her nursing career. And that's where she graduated and went on to get her from LPN to associates to even getting her master's later on in life. And that's me. Yes, you can laugh. The uniforms have come a long ways. That was my last day of nursing school. And I was happy. You can see I'm smiling. I was extremely happy. And when I think back to my nursing education, also had some challenges. I didn't get into nursing school the first time. I had to wait a year. When I went to go to grad school, my advisor told me I shouldn't be in the program. In the middle of my nursing program, I didn't know how I was going to pay for my tuition the next year. So even though we are 24 years apart in these pictures, 24 years apart that we graduated, we still had some similar challenges. Not the same as my grandma Gertrude, but barriers and obstacles that both got in the way for us to get to that goal of being a nurse. Think about our students. Are they still facing some of these similar obstacles? And again, what are we doing about that to remove those barriers and those obstacles? Because we know that we need to have an increased diversity in our nursing workforce. So let's talk about how we can do that. And then to give you a little bit more, as I look at my career path in nursing, I noticed something. I didn't notice this till recently. When I look at the things that I'm drawn to, I'm passionate about, I see a common theme. And that is, I'm tied to projects that help historically marginalized populations. So this is a picture from my first grant that I received, $5,000. I thought it was a lot of money. March of Dimes, my first grant. And it was to create childbirth education classes for pregnant teens that were kicked out of their homes and had to live in this facility. And this is a picture at graduation, where these pregnant teens, when they gave birth, the babies had to stay in the hospital until they found a home for both the new mom and the baby. And you know, that took a long time. Those babies were in the hospital a long time. And then I look to another job I had. I worked in a homeless shelter. That was the most humbling job I have ever had. I learned so much from that job. And then I look at the work that I do now. I work with populations of people who use drugs and who are unhoused. And then my favorite, that brings me so much joy, is creating pathway programs for students from underserved neighborhoods, communities, to inspire them to consider a career in the health professions, preferably nursing, but we also expose them to other health professions. And this is a picture from graduation last year, from a grant I started, 20 students that completed a 6-week program. And when you look at that picture, what do you see? Diversity, somebody said? Yes, when I look at that picture, you may see students from different races, from different backgrounds, from different religions even. I see our future of healthcare providers. Hopefully a lot of them will become nurses. But when I look at that too, I also worry about them. I wonder, are they going to face some of the same obstacles and challenges as Grandma Gertrude, as I did? And how do we make sure that they're going to be successful, not only just getting into college, but graduating and then getting that first job? What can we do to help these future healthcare professionals? So let's talk a little bit about the United States. The United States is becoming more and more diverse in so many factors. When we look at race and ethnicity, you see from now it's about 59% white, and over the years it's going to become increasingly diverse, as you can see from this graph. But look at our nursing workforce. Not very diverse. 80% white, 6.3% black, 7% Asian. One of the goals is we need to make sure that the nursing workforce resembles the population. So some of you may say, why is that important? It's important because if we want to get to that goal of health equity, we need to make sure that the healthcare professionals resemble the population. Because We know when patients look up, and not even just patients, students, faculty, patients, and they see someone that looks like them, they're going to feel more of a sense of, we may have a shared lived experience, might be perceived. I might feel a little bit more comfortable. I will think that you can take better care of me because you understand my unique needs. Healthcare providers from underrepresented groups are more likely to go back and practice in underserved communities. They're more likely to conduct research for these communities. They're more likely to go and advocate for laws and policies and practices that will promote health equity. And so when you have that greater patient-provider relationship, people are more likely to seek care. They're more likely to get that preventative care, and it improves patient outcomes and health outcomes. That's why it's so important. And let's look at language. The United States is one of the most linguistically diverse countries in the world. Do you know that we speak anywhere from 350 to 420 different languages? I didn't even know that many languages existed in the United States. And that the households are getting where English is spoken less and less. In 1980, 1 in 10 households spoke a language other than English. Now it's 1 in 5. When we look at religion, look at all the different religions that we have in the United States. And then when we look at LGBTQ plus community, again, 7.1% of people identify, and that's just people who are identifying in this poll, could be higher. And this one I found surprising from the CDC. Up to 1 in 4 people that live in the United States have some sort of disability, whether it's visual, mobility, hearing, visual, self-care, challenges performing activities of daily living, 1 in 4. So I'm going over this to say, are we ready to take care of this population? How are we preparing our students to take care of this diverse population? Because we're not going to know every culture, we're not going to know every language, we're not going to know everything about every religion. But there are things we can do so we can focus on how we can provide the best patient-centered care. And let's talk about the health disparities that exist. Because the research shows that there are a lot of health disparities that adversely affects patient outcomes. So we're just going to go over just a few of them. When it comes to sexism, we know that when women present with signs of a heart attack, that it's less likely to be diagnosed in a timely manner, more likely to be attributed to stress or a GI symptom. And when we delay diagnosis, we delay treatment. And when we delay treatment, that increases the risk of mortality and morbidity. There's a 2020 study that showed that we also get less effective treatment than men, less likely to take aspirin, less likely to be prescribed ACE inhibitors, less likely or take longer to get angiograms, which again, all of these contribute to increased mortality and morbidity. And Black maternal health. Black women are 3.3 times more likely to die during pregnancy than white women. And it's not related to socioeconomic, education. A lot of it is discrimination, not being heard. As a women's health, you hear this, nurse practitioner, I hear this all the time. I was telling the person I had these symptoms, but it was ignored. Look at Serena Williams, famous. Money, everybody knows Serena Williams. She was complaining of having shortness of breath, and it was blown off. And she wound up having a pulmonary emboli. This story happens way too often. And 80% of these deaths are preventable. LGBTQ plus community face a lot of stigmatism, difficulty accessing healthcare system, up to 30%. And then stigmatized care that they receive, from coming into the door, being called the wrong name, mispronoun, the stares. How is that going to make you feel or want to come back to that healthcare facility when you receive that type of care. Practitioners that do not know how to provide gender-affirming care. That causes increased stress, that causes increased anxiety and frustration. And then I'm not going to go seek care unless I'm really dire need of seeking care. So now I'm not getting my preventative care. I'm not getting my mammograms. I'm not getting my colonoscopies. What does that lead to? Showing up with later stages of disease such as cancer, which are much harder to treat, which can lead to increased adverse patient outcomes. Islamophobia exists. We have studies from 2016 that says Muslim patients face discrimination when they access the healthcare system. They're not heard. Delayed diagnosis. That leads to increased anxiety, frustration, and depression, all because of discrimination against religion. So these are the health disparities, just a few that I'm naming. So in our curriculums, are we talking about this? Because for us to find solutions, we have to understand the problem first. And now let's talk about our students' experience. Nursing school is tough. It can be very hard for some students. Some of our students, particularly underrepresented students, they face things such as microaggression. And I always, that word micro, because they don't feel micro, these aggressions. But everything from jokes that are inappropriate, to being in a curriculum that is embedded with stereotypes, to faculty and clinical instructors that disproportionately scrutinize everything the student is doing, to patients that say, I don't want you taking care of me. How about inequitable policies and practices? Everything from admission policies, where we spend so much time focusing on standardized exams that we know are embedded with bias, instead of looking at other factors such as resilience and critical thinking and lived experience that we know are predictors of a student being successful. So not being able to even get in the door. And then our progression policies. How many of us had that 2 strikes and you're out? Okay. Not knowing that a student could be going through some really serious life predicaments, and not being flexible and just being quick to expel students instead of listening to their stories and finding ways that we can remove those obstacles so they can be successful. Inadequate support, and that's emotional support. That could be academic support, support from faculty. When the students are struggling, do we have tutoring, whether it's peer tutoring or other forms? Advisement, to financial support for our students, to just believing in our students that they can be successful. I remember a time when, you don't do well on a test. Some students are told, well, maybe nursing's not for you. Maybe you need to slow down. Maybe you need to take a semester off. When students aren't able to do that. And feelings of isolation or not being included. You know when you're the only one in a room. You look around and you realize people don't look like you. And that affects your academic performance. You're less likely to participate. You may be frustrated. You don't feel like you belong. It affects your self-esteem, which can affect academic performance. And then lastly, financial challenges. And again, these are just some of the challenges our students face. But we no longer have programs where, remember back in the day, you graduate from high school and you go to nursing school. You live under mom and dad's house, you don't have to worry about any bills, you got food on the table. That's not our student now. A lot of our students, they have families. They have rent to pay. They have mortgages. And I can't tell you how many times I've heard students say, well, they told me I can't work while I'm in nursing school. Well, that's not possible for a lot of people. So how do we help to make sure we remove these barriers? So students, yes, they need to work while they're in school. What are we doing to remove some of these barriers? And then you graduate. But now you enter the nursing workforce. There, we make it difficult in our nursing profession sometimes. There was a study done by the National Commission to Address Racism in Nursing. This was done in 2021, where over 5,000 nurses were surveyed. 75% of nurses witnessed racism in the workplace. 75%. 63% personally experienced racism. And 57% of nurses were brave enough to report it, because we know it takes a lot to go and report a fellow colleague or report an incident. But yet, when they reported it, 64% of those cases, nothing changed, nothing was done. So you think if something happens again, I'm going to report it? Probably not, if nothing was done the first time. So as a nurse in that environment, coming to work every day and seeing this, how does that make you feel? Think about the emotional distress. Think about job satisfaction. I'm not going to want to go to work when I face these issues, these challenges. And over time, what will eventually happen? They may leave the profession and say, you know what, I've had enough. And that's the last thing we need during this nursing shortage, is to lose nurses. And let's not think that the racism stops just from nurses to nurses or towards nurses. Those same behaviors are happening towards patients also. So I state all this to say, what are we doing to promote health equity, to reduce racism? And a lot of our institutions, we're taking wonderful measures to increase diversity, equity, inclusion. We have initiatives, we have holistic admission policies and practices to try to increase and diversify our nursing workforce. But then we have laws and legislations that hinder some of our efforts, such as there's laws that are passed now where you can't talk about racism, you can't talk about LGBTQ plus topics, you can't talk about bias or discrimination. Or we have the Supreme Court ruling against race-conscious admission, or what we call affirmative action. Those same policies and practices that we put in place to help create equitable admissions for historically marginalized students is now gone. How is that going to affect us diversifying our nursing workforce? And then we have prominent institutions with some experts that are in this room who have come up with guidelines and statements, recommendations, such as the Institute of Medicine, that states that a more diverse nursing workforce is necessary to achieve health equity. And the Future of Nursing report states that nursing education programs, including continuing education in the state boards of nursing, should ensure that nurses are prepared to address social determinants of health and achieve health equity. And last but not least, our AACN Essentials specifically call for nurses to design policies to impact health equity and structural racism within systems, communities, and populations, and advocate for the promotion of social justice and eradication of structural racism and systemic inequity in nursing and society. That is a mouthful. That is a powerful statement. So the question is, are we doing this? Do we have competencies to ensure that our students are meeting these guidelines? Are we talking about the interconnection of systemic oppression, such as we like to say the isms, ageism, sexism, ableism, the phobias, transphobia, xenophobia, homophobia? Are we able to connect how that affects the social determinants of health and how that then affects health outcomes? Are we teaching our students this? For example, if someone lives in a neighborhood, has a low socioeconomic neighborhood, that means that in that neighborhood, they may have a food desert or lack the access to healthy foods. They may live in a neighborhood where there's high crime, where safety is an issue. They may live in a neighborhood where there's no gyms, there's no park where we can exercise. We know that promotes health. Live in a neighborhood where the schools, we do not have the best quality of schools. And if you don't have the best quality of schools, you may or may not get into college. And if you can't get into college, then you can't get that degree or that career. And if you don't have that career, then you can't get that job that's going to provide a nice salary and great health care. Do we see how that's all connected? And if you don't have access to those resources, how that can adversely affect your health outcomes or your health. We can look at somebody's zip code. People that live in affluent neighborhoods have a higher life expectancy because they have greater access to these resources. Are we teaching our students about the interconnection between these three? And also, let's take it to the next step. We can talk about it. Are we empowering our students to say, let's take some action and do something about it? What can we do to reduce the systemic oppression? What can we do to make sure everybody has more equitable access to these resources so that we can improve health outcomes? We as nurses, we are in the ideal position to promote health equity. Think about it. We have the expertise, check. We have the most intimate relationships with our patients. We know about health disparities. We work in interdisciplinary teams where we coordinate care. We're in the communities. We provide education to not only individuals, but populations and communities. So we are ideally suited to advocate for social justice and health equity. And more importantly, we are providing education to the future nurses. And we do this by not only in our clinical practice, but modeling it for our students in our teaching. So we talked a lot about the problem, why it exists, but now let's get into what do we do about it? What are those steps that we can implement as nurses, as nurse educators? So here's the how, just 3. The first is, it starts with engaging in personal development. It starts with us. So many times I get people that come to me like, Kellie, just give me a scenario. Give me a DEI scenario. I'm just going to implement it, and then I'm done. I got my one, we're good. That's not where it starts. It starts with the individual, because we all have our biases, and if we don't address that, it's going to play into our teaching. And then the second thing, we need to look at our curriculums. What are we teaching? What are we doing well? Where are those gaps when it comes to teaching about health disparities or culture or promoting health equity? Where could we be doing something better? Where could we be enhancing our curriculum, adding a simulation, changing the places where we place our students for clinical? And then lastly, we're going to talk about implementing simulations. It's a simulation conference, lecture, to promote health equity. Give you some examples of what we can do. So, starting with self. Being self-aware, reflecting on our own biases. We all have them. I can tell you for me, when I worked at that homeless shelter, I had a bias. I'm being transparent. I thought that people in the homeless shelter were there because they didn't want to work. When I got that job, it changed my whole mind frame. There was a patient I'll never forget that came to me and she said, "You're only 2 paychecks away from where I'm at." And I was like, oh no, I'm not. And then she told me the story, how she was a successful actress, lived in Manhattan, had a family, had kids, and she was raped. And from that rape, she had post-traumatic stress disorder syndrome. And then her marriage fell apart, and her husband took the kids, left. She became depressed, homeless, and that's why she was there. And it made me think, wow, wait a minute, that could happen to anybody. So that bias that I had about people who are unhoused, I think about it totally different now. And you know why I think about it differently? Because I had that experience. Because I worked in that homeless shelter and I was exposed to those stories. That's what helped to deconstruct my bias. Are we doing that for our students? Are we putting them in clinical settings or giving them simulations where they might not have had that lived experience, but they're exposed to it? Personal development. Right now, there are so many, whether it's online trainings, workshops, companies that will come to your institution and doing training on implicit bias or culture, conferences. So what are we doing to seek that knowledge that we need so that, again, we can be better educators at promoting health equity? It takes us to be proactive, to seek those opportunities. Go to those seminars, go to those workshops, so that we can work on self. And cultural humility, to know that it's lifelong learning. We're not going to know everything about everybody's culture, but I'm open to learning. And I ask those questions. And I use that to provide more holistic care of my patients. And are we supporting diversity, DEI initiatives? Again, our institutions, a lot of us are doing wonderful work from recruitment. Are you on a search committee where they're actively looking for applicants from diverse backgrounds? Are you on the admissions committee where you're looking at the policies and practices so that you can make sure that we're admitting more diverse students into our programs? If there's grants that are out there, that whether internal grants from your institutions or external grants that are promoting DEI initiatives, are we taking advantage of that and we're applying for those grants? Are we sitting at the table at our DEI committees and going to those workshops that they're hosting? And then mentorship and collaboration. Mentorship is so important. Are we mentoring other students? Are we mentoring other faculty? And faculty that may not look like us and have the same beliefs as us? And are we looking for mentorship ourselves? Maybe, again, we know that there's work that we need to do when it comes to diversity, equity, inclusion. So are we looking for mentors to help us? Next, let's look at our curriculums. By a show of hands, how many people know that woman on the left, who that is? Okay, I would say about half. And I'll be honest, up until about 6, 7 years ago, I did not know who that woman was either. That is Henrietta Lacks, black woman who had cervical cancer. And in 1951, they found that her cells had this amazing ability to replicate, and they've been used for cancer research called HeLa cells. The problem was they were taken without her consent, and they're still being used to this day, and companies have profited from the use of her cells. Are we teaching our students about the Tuskegee experiment, where black men with syphilis, when we knew that penicillin was an effective treatment, withheld that treatment to see the long-term effects of syphilis? Are we telling the stories about Dr. Marion Sims, father of gynecology, who was performing gynecological procedures on women who were enslaved without anesthesia, because the thought was that black people did not feel pain the same way. And some of those same beliefs are still being thought today. Are we telling these stories? And you know why we need to tell these stories? So we don't repeat history. Okay? We tell these stories so that people have a better understanding why people mistrust the medical healthcare system, why people don't trust the healthcare providers. And then looking at health. What is health? I remember when I was in school, I was told by a professor. If you ever have a test question and it says, what population is more at risk for X disease, diabetes, cancer, always pick black. I still remember that to this day. And I thought it was because of genes, made us more susceptible. And now I know that is not the case. That's race-based medicine, which we know is not accurate. So looking at 20% is healthcare, our access to good quality healthcare. 30% is what we do to our bodies. Of course, if I smoke, I know I'm more at risk for cancer. If I eat bad foods, I'm more at risk for cardiovascular. But what I didn't know, 10% is physical environment, where we live, being exposed to pollution. And 40% is due to socioeconomic factors. Again, are we teaching our students about this? And then importantly, I think this is more difficult to teach. Are we teaching our students how to go from being bystanders, which means watching some injustice happen and not doing anything because we don't want to be confrontational, to being upstanders, that they feel empowered to say something. As we say in New York, when you see something, you do something. That they have the skills or strategies to confront someone when they see some injustice being done. Like that video that I showed. Wouldn't it have been great in that first video as the nurse, I would have pulled that doctor aside and said, you know what? I noticed that you didn't extend your hand to the patient when he reached his hand out. And my thoughts were, that might have made the patient feel like they were dirty or contaminated. And I feel you could at least, maybe given a fist bump, an elbow bump. Do our students feel assertive enough to say that to someone? And are we teaching them that strategies? Like the one I just did, open the front door. What you observed, what your thoughts were, how it made you feel, and what's your desired outcome. This is how we help our students to be advocates for their patients. And I love this slide because this gets at the why. Why do we need to have these conversations? They're not nice conversations. Nobody wants to talk about bias and oppression and racism and discrimination, but we need to have these conversations if we want to find solutions, if we want to address it. We got to put it on the table and let's talk about it. That's why I told you that story about me growing up in Colony, because I'm hoping that by telling you that story, you have not walked in my shoes. You may not have even experienced it. You might not have known that those experiences happen. But by me sharing that story, hopefully it caused a little bit of empathy. And when we're empathetic, it opens our hearts and our minds to say, you know what? I don't know what that feels like, but I know that must have been hard for you. And then you think back to times where ooh, maybe I might have been on that end where I might have caused somebody that same pain or caused trauma. What can I do differently? Maybe next time when I see something happen, I'm going to stand up and be an upstander. That's why we share these stories. And we know it's scary. You're scared you're going to say the wrong thing. You're scared I don't have enough knowledge to even have these conversations in debriefing. Or I don't think there's enough time. We got so much content to cover, there's no time for this. Or maybe you don't think it's important enough to talk about. Really look at what makes us uncomfortable to have these conversations, and what can we do so that we can become more comfortable. And some of it starts if we're having, for example, a debriefing on a simulation, setting some guidelines. And the first being that the reason for this conversation, we may not agree. We may not come to a common agreement, but at least it opens our minds to listen to different perspectives. And that laying the guidelines to create a brave space so we can have these conversations where emotions are okay. If you cry, you don't have to apologize, it's okay. That whatever we talk about in this room, we're going to keep within this room, confidentiality. That if somebody says something that offends you, speak up. It's okay, say something. How are they going to learn unless you tell the person? But we're going to do it in a respectful way. We're not going to attack the person. We're going to address the statement or the behavior. And also we need to have grace because we all make mistakes. I say wrong things sometimes, but we're going to come from a place of learning and understanding and not accusing someone. And that we are not a representative of our community. I am a black, heterosexual, cisgender woman. I do not represent every black, heterosexual, cisgender woman. I represent Kellie Bryant. So these are the conversations we need to have. And what's the best modality? I'm not gonna say the best, but I'm very pro simulation. Simulation is the ideal environment to have these discussions, because we can practice, deliberate practice, we can get immediate feedback, we can have scenarios around taking care of culturally diverse patients, we can have scenarios where we're practicing those bias mitigation techniques, we can have scenarios where we're addressing social determinants of health. For example, think of a scenario where you have a patient that had congestive heart failure, being discharged, has all these referrals to see all these specialists, a slew of prescriptions that need to be filled, but they don't have insurance. They have no money for the prescriptions, and they can't get to those specialists that are all over the town. What about a scenario where I'm the nurse, and I walk into a room, and I identify myself as a nurse, and that patient keeps on saying, "Housekeeper, go take my trash out." What do you do as a learner? How do you address that patient? What about a scenario where I'm getting report from another nurse, and they refer to my patient as a gangbanger because they were a victim of a shooting? How do I address that nurse? These are all scenarios that we implement, and they're great learning experience for our students. And it helps because they practice over and over, so when they confront us in real life, they'll be prepared. And then when we're creating our scenarios, we have to be mindful. We need scenarios that are as diverse as our population. We need to have different religious faiths embedded in our scenarios. Scenarios around mental illness, scenarios where the persons may not speak English, where they may have difficulty hearing. How do we communicate with that patient? What are the resources? Do the students know what resources to use? A scenario where the patient has to take care of a transgender female patient. Are they able to provide that gender-affirming care? But when we have these in the scenarios, there has to be a purpose, not just to stick it in there to say it's in there. The students have to do something with that outcome. And when we create these scenarios, that we're not perpetuating stereotypes that will cause more harm than good. Do we have these scenarios in our curriculum? Because we definitely got congestive heart failure, we got diabetes, we have all those medical conditions, but we need to have these scenarios also. And we can't forget about our best practices. Whatever scenarios we create, we need to make sure they're grounded in the healthcare simulation standards of best practice from ANACSL. Are we making sure we prepare to run these simulations? Do we have those guidelines that we're going to go over in pre-brief to create that brave space? Did we pilot test that scenario? Did we maybe vet that scenario with someone else to make sure we don't have those stereotypes embedded in our simulation? Do we maybe need another co-debriefer because we don't feel we might need some help with this scenario? Is this the perfect scenario for an interdisciplinary simulation where we're bringing in other professions and learning from, with, and about each other? And how are we evaluating these simulations? We still want to make sure that they're effective simulations and following these best practices. And I want to end on a quote that this is from the Future of Nursing report that says, "Being a nurse means being aware of social injustices and the systemic racism that exists in much of nursing, and having a personal and professional responsibility to challenge and help end them." And we all in this room play a role in promoting health equity and being those advocates that we want our students to be. And we have the tools. We have the Future of Nursing report. We have toolkits. We have resources. We just need to use them. So my call to action for all of you in this room today is, what is one tangible thing that you can implement when you go back to your institutions, whether it's in your practice, whether it's in your curriculum, one thing that you can do to advance health equity. And you all have your phones, right? I'm gonna ask you to bring your phones out for a second. Bring your phones. I want you to put in there one thing you're gonna do. that'll keep you accountable. And if you want to take it the next step, text that to somebody who's going to check on you in a month and see if you've done that one thing. Okay? One little thing. That is my call to action. And I just want to say in closing, just thank you. I have to acknowledge, number one, Grandma Gertrude, who passed away this year. Without her, she paved the way for me. She paved the way for others. I forgot to mention, she became a nurse educator herself. And I am so thankful for her. And I'm also thankful to the simulation leaders who, again, have paved the way for me and so many other simulationists. The Dr. Kim Lighton, the Dr. Susie Cardone-Edrin, the Dr. Pamela Jeffries. I just want to say thank you. Dr. Kenya Beard for being a DEI champion and helping push this initiative. And my Sim sisters, I can't forget about you. You know who you are. Thank you. And last but not least, I want to send a special tribute to Dr. Debra Spunt. She was a true pioneer and has paved, I don't even say paved the way, was so ahead of her times when it came to simulation-based education. And without her, we wouldn't be where we are today. So again, I want to thank Debra Spunt. So thank you. Thank you for being here with me today. Thank you so much.
Good morning, and it's great to see everyone again. I hope you enjoyed your last evening with friends and colleagues at the summit. I am Dr. Janice Bryant, Chief Program Officer at the National League for Nursing and Director for the NLN Center for Transformational Leadership. Thank you, Kellie. It has been wonderful starting our day listening to you talk about preparing the next generation of health equity advocates, the changes to the system that are needed to create sustainable plans for health equity, and how simulation can prepare learners to care for diverse populations, along with so many other insights. We thank you. I want to also extend a special thank you to Laerdal Medical for making this session possible. We are celebrating 20 years of collaboration and support on so many projects between Laerdal and the National League for Nursing. It has truly been energizing and rewarding and a partnership that is everlasting. And it has been both a privilege and a pleasure to work with our dear colleagues at Laerdal. Let's give them a round of applause. Now, I would like to introduce and invite Rosie Patterson, Vice President of Sales North America, Laerdal Corporation, to come to the podium to make a special presentation.
Thank you, Janice. Good morning. It is such an honor to be here this year to celebrate 130 years of NLN history and 20 years of a fantastic partnership between Laerdal and the National League for Nursing. We're gathered here this morning to celebrate nurse educators and the wonderful work they're doing to move simulation forward and the future of nursing education. This lecture honors Debra Spunt, and she pioneered simulation way before her time, as you heard Kellie say. She was the pioneer who used simulation in education and strategically directed one of the first simulation centers in the United States, the University of Maryland. As many of you know, I had the privilege of working with Debra for several years. And I know that she would be, as indeed we all are today, so proud of her legacy. Dr. Kellie Bryant and her many esteemed colleagues continue to champion simulation in nursing education. It is in this spirit that I would like to recognize the directors, both past and present, of the Debra Spunt Simulation Center at the University of Maryland School of Nursing. They are past directors Dr. Mary Fay, Dr. Regina Twigg, and the current director, Dr. Amy Daniels. If you are present, please stand and be recognized. And I am pleased to say that Debra Spunt's daughter, Ellen Spunt, and her fiance, Zach, are with us this year. We're so proud of your mother's work, Ellen, and we're so glad to have you with us this year. You just need to know you were the apple of your mom's eye. And it is with sincere appreciation that I would like to congratulate Kellie and thank her for presenting the 2023 Spunt Lecture. It's a great privilege to present you with this beautiful, coming soon, crystal, and recognition of your leadership and your lecture today. Thank you, Janice. I hope you will all join us again in thanking Kellie for her wonderful presentation.
Thank you. That was beautiful. Thank you. Thank you.
We're so pleased to have had this wonderful presentation, and it has given us a lot to think about as we go forward. Now, please go and enjoy the coffee, exhibits, poster viewing, and personal connections in the expo. We will see you again at 10 o'clock for our national faculty meeting and the NLN Chair's valedictory address, followed by the annual business meeting and the NLN Chair's inaugural address. Thank you so much for your presence.